Hi, and welcome to the At Peace Parents podcast. I'm Casey, and I'm here to empower you in your decision-making as a parent of a demand-avoidant child. My goal is to share insights that will generate aha moments and support your connection with your child. I'm a mom of two amazing little boys, one of whom is PDA, and I've worked with hundreds of parents just like you to teach them how to lead their child out of burnout and find the clarity, peace, and sense of community they need. Hi, everyone, and welcome to another special episode of the At Peace Parents podcast. I'm here with Dr. Alex Klein, clinical psychologist, colleague, and friend, and we're going to be answering some of your questions that you submitted. As a disclaimer, we don't offer medical or therapeutic advice, but hopefully we'll support you in getting clarity and have some aha moments as we talk through your questions. So, welcome, Alex.
Hi, Casey. It's great to see you. I love chatting about these really great questions from parents that we've been getting. So I am thrilled to be here again with you today.
Yeah, I'm excited too. We were just saying how we're chipping away at the questions because we have some good ones. So Alex, would you mind reading our first question?
Absolutely. Yeah. Really curious to hear your thoughts on this one. So this one has to do with OCD. So I can't tell if my son is PDA, has OCD, or both. His OCD presents as contamination related, not wanting us to touch him or his things, constant sanitizing. ERP was not helpful in the past. So ERP, for anyone that doesn't know, stands for exposure response prevention. And maybe we can talk about that a little bit more. But ERP was not helpful in the past. Reducing accommodations has not helped. He does not have obsessive thoughts. OCD just never felt right. And I wonder if it's really an expression of PDA or if they are co-occurring. Should I be accommodating him or not accommodating? Can you recommend any resources where I can learn more about this intersection of diagnoses?
Awesome. Okay, such a good question. Alex, would you like to start or would you like me to start?
Go ahead. I'd love to hear what you have to say.
Okay, so the intersection between OCD, obsessive compulsive disorder, and PDA, pathological demand avoidance, in my work with clients and parents is actually the intersection that I find most challenging to support parents with because it is based on a completely different logic how you help it, right? Even though I think both OCD and PDA are coming from parts of the limbic system. Like I've read that OCD is housed in the basal ganglia, which is part of the limbic system, or like the survival part of our brains. And it's also where Tourette's and Alzheimer's and some other sort of glitchy sorts of manifestations of the brain comes from. And so the support is often exposure or pushing a kid through their loop so they don't get stuck there, right? Whereas pathological demand avoidance, I see as housed also in the limbic system, but in the amygdala, which is like our threat detector. And so if the behavioral response is coming from the perception of threat, pushing a kid through or exposing them a little bit more, the just right amount, according to the other logic, can actually push them deeper into the threat response, worsen the behaviors, and traumatize them. And what's hard is that these surface level controlling behaviors like parent described could be either, right? Like contamination for me is always like, oh, that sounds more like OCD. I'm not a clinician, but as parents describe it. But controlling whether or not another person can touch your things, for example, or even controlling where another person can sit, or certain things that could look like controlling or compulsive behaviors could be related to either PDA equalizing or OCD. So the way I approach the question that this parent asked, and this is how my work is designed and really based on where my expertise is, which is PDA, not OCD, is, okay, if you've gone through exposure therapy or if you've treated OCD and it's made things worse, let's trust ourselves, look at the data, and if parents are ready, they can take the leap of let's consistently experiment through another logic and accommodate and see if some of these controlling behaviors goes down. What's complex is that for a lot of the times when I have parents with this concern, it really helps in some ways to work through a PDA lens of accommodation, and it reduces trouble accessing basic needs. It increases felt safety to support connection with the parent. It improves nervous system activation. However, sometimes they see these obsessive or compulsive behaviors worsen because they haven't distinguished between which is which. I always say it can help get clarity to see which is which. And it's not necessarily, I don't view parenting through a nervous system lens or an autonomy lens as a philosophy where you have to ascribe to it completely. It's more like, right, this is a lens. Let's once you get clarity, let's combine it and then dance between as a parent of when you expose and push through and when you accommodate. And that can be really tricky and frustrating and confusing. It sounds like for this mom or dad who submitted this, she has more data about exposure not working and accommodations not making it worse. So I would say continue with what's working and continue to collect data. That's probably an unsatisfying answer, and it's not a clinical answer, but that's how I would approach it if a family came to me with this question. So what would you say?
Yeah, I love that, because I really agree with what you said about sort of data collection, right? So okay, we're trying exposure response prevention, which for example is if child has contamination fears and maybe excessive hand washing, to use a somewhat stereotypical example. Every time they touch the doorknob, they have to go wash their hands for 10 minutes, let's say. So an exposure response prevention might be finding ways to prevent the child from doing it, to work on kind of riding out the urge, tolerating the discomfort of not being able to to do that, right? Which can be much easier said than done. I think in particular with our PDA autistic kiddos who, maybe, and I think this actually leads me to something you said that I also really agree with, that some of the hardest cases I've ever had actually are probably involve OCD, really kind of severe OCD and PDA autistic children who, it's so tough to work with, because of course we really want to honor the child's autonomy, and, but some of these suggestions might be really unwanted, right? About how do we work with this, right? Yeah. So it can be so tough to get buy-in, which is kind of the most important thing, or one thing that we really want to sort of start thinking about early on. Are we able to get buy-in from this child to work on this issue, and how do we get buy-in to work on this issue? So I want to get into that some more, but I mean a couple other things that sort of come to mind, right? Because this parent is asking, right, is it both OCD and PDA, or is it one or the other, right? So how do we think about that? And so we don't really know, right, exactly, without knowing the kid and doing the assessment or whatever. But I do think that we know that there's a high overlap. I think the studies would say roughly 20% of autistic people also qualify for an OCD diagnosis. So that's much higher than a general population, right? So I don't know, PDA specific, autism subtype. I'm not sure. We probably don't have good research, good numbers on that. But I know that this kind of thing is a really high overlap. And we also know that people who have OCD but are not autistic or not PDA, there's a higher likelihood of having sensory issues, actually, which I learned that more recently. I think is interesting. So both groups have, a lot of sensory processing differences, which is really interesting. And both, might have some kind of compulsive or repetitive type behaviors in both OCD and autism PDA. So, there's so much overlap. So I just want to validate that this is a hard question and an important question. I mean, I do think what I see a lot, and this really irks me, is a lot of clinicians who kind of we would hear about these sort of OCD behaviors. Let's say it's compulsive hand washing, and there's sort of an immediate okay, well, we got to do ERP, and you got to prevent that. You got to stop if you're doing it, otherwise you're accommodating and enabling this behavior, right? Like that's, I think, what a lot of parents are told, right? Like you are enabling behavior. And I think logically, I do understand that. And I do understand that concept. And I do think that applies, meaning like, sure, I mean, we're not, the parent might not be kind of getting in there and stopping it. But, another question is like, well, how do we want to try and do that? And how do we want to move away? And what influences whether we even try in the first place? So in my mind, I have several questions that I think about and trying to determine like, what do we do about this? Do we accommodate or not accommodate, as the parent asks? And so one big question is like, are there safety issues? Like, is the kid developing eczema and infections in their hand, to the point where like the child's own goal of being able to play video games or something is being impacted, right? That like are there safety issues that are really hurting the child or somebody else, right? In their sort of medical, physical health, right? So that's a consideration in thinking like, how do we deal with this issue? I mean, I also think a lot about, again, how did we try to get buy-in from the child to work on the issue, right? Can we tie it in to their own goals? Like, I know that you are, it seems like, you really wanted to go like hang out with your friend that one time, but like you spent, so much time in the bathroom washing and cleaning and sanitizing that you couldn't, so I kind of drawing, like, I think at some point, like helping somebody to see, how this might be impacting their own goals and, isn't important. And I think within that, sometimes I like to externalize it. I think we see this a lot in the child therapy world, like externalizing the problem, quote unquote. Like, so the OCD becomes like the OCD bully, I see the OCD bully came for a visit. You can have a funny name or even call it the name of a person that you don't like or something. Like, so, like, I see Uncle Bob just came in the room, right? And we're doing these things, like, how can we sort of team up to fight against that, right? Or to throw the, OC bully in the trash can or whatever it is. Sometimes that kind of externalization makes it feel a little bit less sort of pressure and less of a demand on the kids sometimes, right? But this is hard and there's a lot of individual variability, right? But I'm thinking about like, how do we make this sort of not personalize it so much a little bit, but also, how do we sort of understand why the kid is doing the behavior in the first place, right? Because if it's like sort of a PDA, let's say it's like an autistic repetitive behavior that's sort of soothing for me to, line up these sort of objects on the, on the table, or to sort of like make sure, things look sort of straight and smooth or something like that. And, it sort of has like like the act of doing it itself is soothing, maybe like, lining up the things, like I like that, or, playing with the water in a certain way. And I like the way that looks and feels and it's soothing, right? So that's one thing, right? Like, then I'm not thinking of this as like an OCD thing to try and stop, right? But is it more of a kind of a compulsion that there's this internal feeling of distress and like doing the thing kind of provides me some immediate relief, in a way that is very temporary. Honestly, in OCD, usually it's sort of like, okay, well, I washed my hands and I feel okay for a minute, but then I might accidentally touch, my mom's back and then I have to wash my hands again or something like that, right? And so that is a different feel to it, right? It's not really like kind of a soothing sensory, seeking type behavior. It's more of like kind of OCD driven. So sometimes I think it's important to sort of distinguish between those two things. I constantly feel like a lot of clinicians like don't kind of adequately adapt how we think about OCD therapies with neurodivergent clients. And that's sort of a broader issue. I think that, like, so for example, typically, we might need to go slower, right? Like sometimes in ERP, exposure response prevention, we talk about sort of doing a hierarchy of like what's really hard, but let's start with something smaller. And yes, and taking some time with it. But the time taken for some kids might be like a lot longer, right? And we might need to be able to tolerate that this is going to be a longer process. So we want to be asking, like, are we moving too fast? And is that why it didn't work, right? Did we like try to do this too fast? I also like to sort of, in doing ERP, sometimes I do think we sort of want to, so we know how special interests and, objects of hyperfocus are, really common in PDA autistic folks and neurodivergent folks in general, and, can be a source of soothing comfort, right? So how can we actually maybe find thoughtful ways to incorporate that into, like, okay, I know that you, like, we're working on not washing our hands like for 5 minutes after you touch the doorknob or something like that. Like, maybe what might help, sometimes distraction is really healthy, right? So sometimes we like a healthy tool to maybe like not engage in this compulsive behavior, right? So like, how can we maybe use our special interests in that way, in a way that actually kind of helps us kind of get unstuck in this sort of OCD behavior that we're doing? So that's another way to think about it. A few other points, I'll let you respond. I know I'm going on a lot about this. There's just so many thoughts about this one. But I think, like, with OCD, we also want to think about, and let's say, it's really hard and, things aren't really working. We also know that overall stress and anxiety can absolutely exacerbate, all of the OCD behaviors, right? So it's not like a cause per se. I wouldn't say that like the stress caused OCD, but it certainly can exacerbate it, right? If there's like broader anxiety and stress in somebody's life, like, can we tap into that? Can we say, okay, like, there's too much going on at school, or there's too much tension at home, or there's whatever, factors are increasing stress for the child. Can we reduce the overall stress and like look at what kind of impact that has on OCD? Also, things like medication, right? If your child is able to take medication, if a parent is sort of, on board with that, looking at like, to what extent does an SSRI like really help? Because maybe trying to do ERP with my kid is too difficult, but maybe like actually he will take some medication and maybe that helps a bit. So that might be some kind of low-hanging fruit. And I totally understand that parents have all kinds of views about medication that I really respect. And, I would never pressure somebody to medicate when they don't want to. But that's another consideration there.
Yeah. Okay, so I'm going to try and summarize a little bit. So, one of the things I'm hearing you say is understanding the intersection with anxiety, the pace of how you're moving through it if you have a child who's also neurodivergent, and you talked about how that overlap is about 20%, which makes total sense to me. Yeah, my brain on a Friday afternoon is not able to.
Oh, believe me. But
things.
like, well, I think I just said like just so much different stuff. But I think it's like this question of like, do we do something about it in the first place, right? I mean, that's sort of like a big question. And again, like, I'm thinking about like, okay, safety issues, physical harm, like what has been tried first, right? Another thing I didn't say is there like a whack-a-mole effect where like you kind of can decrease one like OCD like behavior, but like two more pop up in somewhere else. And so
that's
like
the problem that a lot of my parents I work with have, is like they accommodate PDA, that part gets better, but then OCD behaviors get worse. And it's like the ultimate rock in a hard place. I think just structurally working in the medical system, at least here in the United States, for some families I've worked with, unfortunately, sometimes they're met with like, you have to do exposure therapy before we'll consider medication, or you have this sort of rigid program, as you said, that doesn't take into account the neurodivergence, the neuroception of threat, the sensory sensitivities, and either the pace is too fast or there hasn't been buy-in, as you've said. It hasn't been linked to not just consent, but motivation of like, well, I can play my video games if I don't have eczema. And so I think it feels like an all or nothing to parents with the way some of these programs are designed. I don't know much about it, truly. It's just through the clients I work with, but can a parent work with someone like you, like a clinical psychologist who could adapt ERP to the neurodivergent profile, like you're kind of talking about, and you gave great examples? Or do parents usually have to go through like a strict program and protocol where it's like,
I mean,
12,
really good
12 weeks?
Right. I mean, really good question. I mean, I think the ideal situation is not going to be a very strict program or protocol. Usually, I mean, there's going to be exceptions to that. So I don't know if I'd say that about 100% of cases. If this is a case of, PDA autistic kid with OCD, like, we're often going to ideally have someone who's experienced with neurodivergence and with OCD and being flexible with it. I mean, this parent asked about resources. I mean, there is a book called, I wrote it down somewhere. It's called OCD and Autism, A Clinician's Guide to Adapting CBT. Also, there's a couple neurodivergent psychologists that have talked about sort of like how do we adapt therapy for things like anxiety and OCD. Dr. Jeremy Schumann comes to mind. I've seen him speak, and Dr. Megan Neff. Like there are some resources out there, but I know it can be hard to sort of access clinicians necessarily, but there are things we can kind of come across and read, because I do think that when we get too rigid as a sort of a psychiatry field around like this is how you have to do it, like that is generally going to be not a great fit, for I think many of the clients I see. I think we definitely want to be more flexible. And, so for example, if a clinician wasn't taking into account, let's say, so this parent mentioned that, her kid, didn't like to be touched, right? And so let's say there's a sensory component to that, right? Him not wanting to be touched, right? So like, are we supporting the child's, sensory processing needs more broadly, right? As opposed to like trying to work on this as like an ERP type of thing. Like, no, you have to like tolerate being touched without, taking a shower. Like I would not want to do that, right? Because we don't want to handle things that have a sensory basis to it in the same way that we might want to handle something that's like kind of a more clearly OCD like component. So this stuff is so hard to navigate and figure out how to deal with. To your point around like medication, I've probably seen this between 10 and 20 times where, a family has told me that we're not going to try medication until you've done a better job with like behavior modification or ERP, exposure response prevention. And I definitely disagree with that for a lot of reasons. I mean, one is like, I don't think that maybe the clinician is taking into account like how difficult it might be for this kid to engage in the ERP. And in fact, using medication might help the kid be able to use some of the strategies, right, that they might not be able to use without it, right? So withholding medication to like a family and a kid that are open to this, like that's definitely, I see as problematic. Even though there's lots of situations where I agree with holding off on medication. This is just not like one of them, and I'm not talking about situations where we're talking like a week of OCD behaviors. I'm talking about situations where this has been a more longstanding issue. Yeah.
Yeah. Just to share a little bit about my personal experience. So I was diagnosed with postpartum OCD.
Yeah.
Led to avoidant behaviors or cognitive loops. So after Cooper, my PDA son, was born, I would have like extreme intrusive thoughts about harming him or like throwing him off a balcony or drowning him. Sorry, trigger warning, too late. But it was like these thoughts would come from nowhere.
Oh yeah, the intrusive, right? OCD thoughts. Yes.
And my compulsion was avoidance, right? I remember going when he was 5 weeks old to a museum with my parents in Washington, D.C. to try and get out of the house. And like, I wouldn't walk near any of the balconies, or, I wouldn't go in the bathroom or near bathing situations, like bathing him for a long time before I started a higher dose of medication, because I was so afraid that these intrusive thoughts would propel me into behaviors, right?
Yeah.
And then I would have other intrusive thoughts about like things happening to my husband whenever he left the house that were pretty graphic. So like, I do see this as a different mechanism, right? Like, right. I don't identify or relate to the mechanism of like, there is a perception of a loss of autonomy and equality that's subconscious. And then in order to get back to safety, I control something, often another person or their things, the weakest or the safest person. So that's another place to look, is like, unless you have an internalized PDA, or is like, sometimes when parents ask about the OCD quote unquote behaviors, it's actually equalizing behavior against another, right? It's like controlling the mom, whether or not she can eat at a certain time, or destroying her things specifically, or hovering around the other kid impulsively.
Yeah. Really, I really like that you shared what you said about your own sort of postpartum experience. I mean, sadly, those things are like more common than I think people realize, like having thoughts like that are so like antithetical to your whole being, Casey. Like, obviously, you're never someone who would, consider, I mean, it's like these are unwanted, that's really a very distinguishing feature, I think, sometimes to think about OCD, versus like sort of something more in the autism realm, like is with OCD, I mean, often like a very unwanted intrusive thought, like we don't want to have that thought, right?
Yeah, like where did it come
And
from?
like maybe the avoidance, of like not, going with my baby near the balcony, yeah, like I don't know, temporarily kind of keeps that thought from getting too big, but like it's very temporary usually, right? That's one way to
Yeah.
think
And I
about
was,
it.
I was afraid to leave the house too because it was like I was I would get around on the metro and there's a metro platform and it
Right.
was like there were balconies or high up places and it was quite debilitating, but
Yeah.
as an example of exposure not being bad per se, like it was like the pushing through and like, okay, like practice giving the bath and practice these different things, maybe with another safe person around. It was like moving through the stickiness, but I think my brain would have reacted differently if that was coming from a place of like a PDA neurotype and someone was like, no, we have to do this. I'm going to sit here with you. Let's do X, Y, and Z exercise. We're going to run the bath. You know what I mean?
Right. Yes, I do. Yeah, and we all have sort of different abilities to kind of, to think about like, well, what comes up for us when like we are running the bath or not washing our hands after touching the doorknob, like distress, anxiety, thoughts around something bad happening, some uncertainty, since often you can think of a lot of these OCD behaviors as like an attempt to sort of get more control and certainty when things are not always 100% certain. I do think about this a lot. Like sometimes the sort of exploration, while I do think it's worth trying and looking at with every person, every kid, how do they sort of think about that? I do know that like some autistic people might have a harder time sort of identifying emotional states or like even really tuning into their own internal body cues, right? And really understanding that. I mean, sometimes I think that a reason that therapy might not work as well with some autistic people is that there's like actually kind of too much emphasis on that in a way that can feel like a cultural mismatch almost. Like, so,
Mm.
if that's just like somebody's more kind of, kind of cognitive and analytical and logical and just has sort of like I don't know, like sometimes sort of trying to do therapy that sort of is like very sort of focused on like what are the sensations and urges, like that's not always going to work. And it's not the same as saying like we don't try, I mean, there might be some opportunities and something important there. So I don't say this is like every, I don't think we handle these things the same way with every person regardless of diagnosis, but it is just another example of how I think this is like really hard to work with. So like typically, but again, there's this still big question of like, how much is this getting in the way of the child's own goals? Like you probably did want to be able to walk with your baby near the balcony and, take a bath with him or whatnot. Or so like if we can find some of that buy-in, then hopefully there's something to kind of like work with. But I just really know that these things are easier said than done with some kids. And it is
Yeah.
such a painful decision sometimes when your kid doesn't want to work on it, but it's like the OCD is really harming them in some way. Like these are why some of these cases like become some of the most challenging, heart-wrenching cases, because like we want to give that autonomy, but what if we can't get it?
Yeah.
There's always going to be ways to keep working on it, and there always can be indirect ways to try and sort of reduce the size of this problem. Sometimes it's not a black and white thing, but it's more like how much is sort of like OCD kind of impacting all of our lives. Like right now it's like a 9 on a scale of 1 to 10, but like can we make it like a 4, and can we live with that? I mean, like, I don't really look at these things in sort of black and white ways, but there really are different approaches and ways of thinking about this. Like I definitely know psychologists that are very like it's kind of all or nothing. Like we're either always not accommodating or like not allowing the compulsive behavior to occur, or we are. And, like I don't really see a sort of black and white way, but I do know that I just really approach this stuff with a lot of empathy for families, because I think that like this is really tough to go through. And like I said before, sometimes I think parents get a little blamed, like, oh, well, if you didn't start if you weren't accommodating your child so much, you wouldn't be enabling this behavior. And but again, I don't see it that clearly. I don't see it like that.
Yeah. One last question on the OCD topic. So, there's this idea that if you don't sort of like nip it in the bud when you first see it, then it's just going to burgeon or explode into this worse and worse thing exponentially, right? But one of the things we've been talking about is like pacing and consent and identifying other root causes, maybe sensory, prioritizing, right? Which makes a lot of intuitive sense to me, especially the framework that I work with families through.
Yeah.
But like, what is the risk of waiting from a clinical perspective? Like, let's say, and I know it has something to do with what you just said, which is like, how big is this problem specifically in the life of the child right now?
Yeah.
But let's say it's a 6 or a 5 and we're noticing it. We're also noticing neurodivergence, PDA. But the narrative is sort of like, we have to do this now or it's just going to keep getting worse. Like, how big is the risk trying out accommodations to see if it's PDA or OCD, or, establishing felt safety and trust over the course of months through accommodations, and then gaining consent and moving into some more exposure? Like, as a clinician, do you see that being a huge risk, or like, how can we think about the risk as parents?
Yeah, that's a great question. I think the last part of what you described about sort of like increasing accommodations, reducing overall stress and demands, and sort of like seeing the impact on it, and then maybe trying to get some buy-in over time, because it's probably generally more likely to go that way. I mean, this is assuming that we don't have buy-in from the child to work on this right away, right? If we did, that's one thing, right? But I think, again, typically the families I see, like that's not the case. So, I think that, I can empathize with this worry. Like, if we don't stamp this out right away, like it's going to become a thing. I mean, I think typically if that's the space we're in, like you might be able to stamp out that one thing, but like something else is going to pop up. So I guess I don't see that as sort of like necessarily often a robust solution to to this broader issue, because I think, again, we still want to look at broader stress and anxiety, how that exacerbates symptoms, or do we have medication involved, like how much buy-in is with the kid, do we know? And so I think, and sometimes early on when OCD behavior appears, like we don't know whether there's more of a sensory component, more if this is about soothing, or maybe we need some time to sort of see how this is really impacting. Because again, like if a kid sort of like only wanted to wash their hands, like, after touching a doorknob every once in a while, like, I don't know, I don't know how much time I'm spending worrying about that, right? If this is like a once a week thing, but if it's like 20 times a day, much different, right? So, some of this depends on like to what extent this is an issue, but oftentimes early on, we don't know. So I don't think I would say that to the family who kind of let it go to some extent, I would not say that, oh, if only you had stomped this out immediately, then there would be no problems here. Like, I think the problems are going to be there either way, and they're interconnected. Yeah. But it's, so like, absolutely, I see OCD symptoms go down sometimes when, again, we've like increased accommodations, reduced demands, all the things, right? But there's enough variability that it's sort of hard for me to make like very general statements about that. I think, like this is going to be the path. This is going to be what happens, which is why I agree with what you said earlier around like sort of a data-driven approach, like what's happening over time as we're doing this kind of stuff.
Yeah. Yeah, I think we both have that, like, let's get into the nuance. Let's get into the gray space when we talk about these.
Have you seen that too, Casey? Like where, like, we've reduced demands, we're sort of have an accommodation lens, and they're, like, are you seeing frequently like OCD behaviors going down with your clients?
Yeah, I mean, certainly some and others no. And that's why
Mm,
this question is such an important one. Like, and it's often on different dimensions, right? I think with the hardest cases, as you said, what we see is the accommodations really help in a certain area and maybe not exacerbate, but not nip in the bud the more loop OCD, sticky brain stuff get worse. And that, I've had a lot of families who have had a child in a program in a hospital, and, it gets maybe at the root of some of these sticky OCD or behavioral driven things, but then there's this really intense separation from a safe nervous system. There's a big loss of autonomy. And then when they come out, the PDA side really escalates and the nervous system escalates and it's impacted trust. And it's like, it's just
mm.
sort of this, as you said, whack-a-mole, right? So, I mean, I think for these kids, what we need is what we've been saying is an adapted, trauma informed, slow paced, prioritized exposure, potentially allowing the parents to explore and trial and error a little without shame, and really prioritizing the felt safety and trust between the parent and the child, which often requires accommodations before we push. And my son doesn't have OCD, but he has generalized anxiety. And it's taken us a couple years and SSRIs for him to be able to push him through his sticky spots. Even though they're not OCD loops, they're like anxiety loops. And
Mm-hmm.
exposure on the very smallest scale has supported him to try things like
Mm-hmm.
sports or
Right,
after school activities or
right.
going places, but it was only with that like solid foundation of like, I'm never going to make you do something that feels traumatizing or too much.
Yeah. Yeah. That you
That,
built that trust
yeah.
over time. Really good point. Yeah. Which is why, like, I don't, this, I think this is why some of the hardest cases I've come in contact with involve OCD and PDA, because like cases where kid is like, there's like physical harm, there's medical stuff,
Yeah.
like
Yeah.
so hard because all I want to do is get buy-in and get trust. But it's like, how do you navigate when you get to that point? Really tough. But yeah, but a lot of cases, yeah. I mean, I do think sometimes we really can, like you said, get to a place where you've got some more buy-in, or there's more trust. I mean, I think that, like, again, the more sort of stressed and anxious, a kid is, like, oftentimes the more OCD symptoms we see. So I would never recommend doing like OCD ERP for OCD without, like, again, seeing if we can reduce overall stress and anxiety. Like, that's going to be really important. And then I think always focusing on the trust in the relationship. I mean, I've had some families who successfully kind of got their kids out of ADHD, OCD loops, like purely using like kind of humor and like playful distraction and like, just like really hard. I mean, it's a really like a Herculean effort, I think, for some families who are really trying to do this. But it can happen for sure. But like doing it in a way that is not going to feel like, we're coercing the kid or is so critical.
Yeah. Well, our hearts go out to this mom and dad who asked this question and all of those who are navigating this intersection. I'm glad we're talking about it. Because when, I see the question, who's the expert? I'm like, I actually don't know who to point you to.
Right.
Like, Alex, should we talk about this?
I don't feel like the expert either. I didn't, although the people I named might be some good people to check
Yeah.
into.
Melissa
Yeah.
Neff, and who is the other one? We can put it in the show.
Jeremy Schumann.
Okay. Awesome. I'm going to check them out. I know Melissa Neff, but not Jeremy Schumann.
Okay.
Very cool. All right. Should we do our second question? Another doozy?
Yeah.
You want to read it?
Sure. Okay. So this is a question from a parent who's looking for suggestions for how we can stop our child's physical aggression, especially when it's geared towards a sibling in the moment it's happening. I'm highly triggered when I'm hit by my child or when he goes after his little sister. I don't know how I'll be able to deal with this as he gets older, and desperately would love some tools that you've seen work. His violent fits cause by far the most helpless of our moments. And although we're using lots of your strategies to keep accumulation from happening, it still does. And often myself or my daughter are the targets, blamed for things we didn't do. and he will start throwing our things or hitting. I know this isn't what he wants to do, but I feel like I have to teach my daughter and son that they have the right to be safe and not abused, and that her father and I will keep her safe. Not sure how to do that, though. Such a good question, because it really taps into two concepts we got a lot of questions around, was both like impact on siblings and how do we think about that, or how do we mitigate impact on these kinds of things of behavior, and also just sort of how do we deal with aggression and emotion regulation strategies more generally. So many questions that sort of centered around this. So yeah, I'd love to hear how you think about this, Casey.
I actually just did a podcast episode about what I call risk mitigation. So in the program I run with families, we have 9 accommodations that are proactive and all the time, right? We're sort of changing the way we are with our kids, the way we talk to them, the way we move, lowering demands, all sorts of things. But then there's 3 responsive accommodations, which happen in the moment, right? Which are diffusion, which might be like your child swearing at you or saying that you said something, saying like the house is blue when you're looking at it and it's red, or blaming you for something they did, like spilling a water across the room or forgetting their water bottle, blaming you for it. Those are cases where we can use diffusion of just like, oh, the kid's in the survival brain, we can diffuse and help them back into the thinking brain. That's much easier than the next one, which is de-escalation, right? So I have like 8 steps for de-escalating, but that is generally focused on like a one-on-one situation where it's you and another child or teen and no one is at risk of physical harm, right? And in that case, it's like we often encourage, as part of those steps, like the sibling to either we remove the sibling or the sibling removes themselves. The third, and I think most challenging, quote, accommodation is what is actually decision making. It's called risk mitigation, right? And that is choosing the course of action that is least likely to result in harm to all involved, which includes the parent and the siblings. And it's really important, you said this word mitigation, because it doesn't mean there's not necessarily going to be any harm, because in the moment that the child is in, this is my perspective, my perspective. The moment that a PDA child has reached fight flight, they're subconsciously not just perceiving danger, they're perceiving life threat, right? They're fully in the survival brain. And as this mom says, and she knows, like, he's not doing it on purpose, right? It's just a survival response. And so we can mitigate risk using certain strategies, but they're deeply unsatisfying. And I think moving from the mindset of solutions to decisions can really help parents. And I'm speaking from experience. What do you mean by that? Yeah, mindsets to decisions. Okay, so like, for example, I used this example recently, but I'll actually use a different one. So for example, I'm on the trampoline with both my sons, and one is 5.5 and in burnout and has a hair trigger fight flight response, and he has so much arousal and activation that anything can set him off. And when it happens, he's going to fixate on harming me or my 1.5-year-old. Okay. Once that tipping point hits, I don't have a lot of solutions, right? I could put my body between me and Cooper and the 1.5-year-old, which I would do all the time. I could be on the receiving end of the violence. And, I know it's different to have a 5.5-year-old than a 15-year-old in this situation. I've worked with many families who, we're not talking about 5.5, we're talking about 13 to 18. Right. So it's a different decision. I could take my 1.5-year-old and remove us from the fight or flight, but then I have a 5.5-year-old who might elope, which he would do, because I've tried all these decisions, right? Like, me and the 1.5-year-old are going to set a boundary and remove ourselves. And then I have a 5.5-year-old without shoes on running into the street or down into the neighborhood, and we have to chase after him, right? And what's so challenging about these decisions is that even if we're not trying to stop the behavior of the PDA individual in fight or flight, any perceived loss of autonomy, removal of a safe nervous system, or us making a decision that they don't consent to is going to drive them further into the survival brain and escalate the violence. So we have a lot of situations where we have like a mom who has, let's say, a 12-year-old PDA-er, right? Mm-hmm. And they're in burnout. They've just come home from school. Maybe there was a hospitalization because they were working through the lens of behavioral modification. So they're a month out and their child is just so far past the threshold that things can just tip them off. And all of a sudden it's bruising, biting, hitting, destroying things towards the mom. And if the mom removes herself and locks herself in a bathroom or goes into a bedroom, the violence escalates either towards self, towards sibling, or towards the dad, right? So it's this it's this horrible, horrible logic, right? And so the first thing I think what's important for parents to understand is like, there's not some strategy that I know of that I'm hiding or like someone else knows of, I don't think, where you're not working with this logic of the cost benefit decision making of you're either activating or accommodating.
Yeah.
In the moment, right?
Right.
Boundaries, limits, removing yourself, they will all increase the fight or flight response. And so we need to recognize that and also name that doesn't mean it's the wrong decision. Right. And so one of the things we want to do is think ahead of time about risk mitigation of like removing things, sharp objects, being in rooms where you are not near windows or mirrors, really thinking through like, where can I play safely? And like for me, the trampoline or our padded basement was not ideal, but I could zip up the trampoline. So there was something that would slow my son down if he was going to.
Right.
Or, making an action plan beforehand, talking to your spouse or a neighbor, like the neighbors would text when they would see him run because, I was sometimes tending to the 1.5-year-old. This is before I had more childcare support. My husband was working a really intense job. And then it becomes deciding between 2 or 3 really crappy options, but not blaming ourselves for not finding an option C or a magic bullet.
Yeah.
And then examining both structural constraints of your life, like an example of like, this isn't the reason we moved to Michigan, but it was like one of 100 parts of the calculus of like, I can't stop my son from running away from me. And I can't physically restrain him because adrenaline's running through him and he's physically attacking me. But I can be in a small town in Michigan surrounded by cornfields where like there aren't that many cars versus Washington, D.C., right? I can take him to a park where if he does run into the parking lot, it's not packed and it's not a metro parking lot, right? And then also looking clearly and without judgment here, but just like realizing that sometimes the causality of like, well, we've done everything we can and we've lowered demands, but then you take a close look and it's like, well, the kid's still going to school and therapy and he or she is reaching this threshold. Or the parents accommodating sometimes and then trying to teach and correct in others.
Yeah.
And that's not to blame, but it's like each one of those interactions and moments is pushing the child to the threshold where we see that tipping point. And I'm not saying that's what's happening with this mom.
Right.
But like those are the 5 things I encourage parents to think through as a next step. And sometimes when we see how shitty the options are, it shifts our thinking. Because I think a lot of us get stuck trying to, as I said, find a solution. Like if I use declarative language, it will stop this. And it it doesn't, right? It's not going to stop it in this moment. Yeah. Like it might help in diffusion, but if we're in risk mitigation, we're also in our survival brain and we're in a different.
Yeah.
So that was a little rambly, but
no, I love it.
First part of the question that I would say. And I have a lot of compassion. Like I have been in this situation. I have put my body between my kids. I have received, actually in the paradigm shift community today, there was a discussion that I felt very much a part of, which is like, is it normal, even though my child's out of burnout and no longer violent, to have a startle response around them? or to
Yeah.
feel your
Well,
body
that's
react when they like are
trauma. Yeah,
dancing. My
even
son will
parents.
move quickly to do something like, "Hey mom, look at this. It's a football." And like my whole body's like,
Right.
and I don't have that with my younger son because it's just like I have
Right.
that hypervigilance to like something's going to come at me.
Yeah, because you've experienced, it's traumatic for families too, right?
Yeah.
To experience this kind of stuff, right? So of course there's going to be that lasting hypervigilance sometimes. Yeah.
That's the part of her question that's like, what should I do? Or like, is there a solution? What's the strategy?
Yeah. I mean, I really agree with everything you said. I don't like have a lot that's that different because I was going to say similar to you, right? Like, this question, how do you handle this in the moment it's happening, this physical aggression? Like, yeah, like you said, I don't think anyone's figured out the magic bullet there. I think it's like, how do we, once we're in that red zone, fight or flight, limbic system, however, whatever we want to call it, like, yeah, it's like, how do we, get through this moment while mitigating the harm? I think that sometimes like maybe there's some concrete things that some families can do. So like, for example, I've had some families have some success with like making sure they have like big cushions or those like yoga balls or therapy balls around that they're kind of large and they're kind of like putting them. I even have one kid that actually is sort of like, I don't think it would be fair to say his aggression is just about sensory seeking, but there's like a component of that. So like hitting the cushion or the therapy ball like still gave him some of what he needed. And so, I mean, there are occasional situations where that alone actually is like a good strategy in the moment to like have something else that the child can hit that's not hurting anybody. But like you said, I mean, typically it's more like, yeah, how can we sort of get into a safe space? I mean, oftentimes it's not as intuitive as we might think for everybody just to sort of like literally move out of the way, like literally just to get out of reach. And, if there's the other child there, I think both would be doing that, kind of trying to protect your, vulnerable areas, right? But, and sometimes there is kind of a safe space that the child can be directed to, or like an identified, if it's a school or at home, like maybe there is a spot that, oftentimes it's easier said than done. Like, yeah, we've identified this calm corner, but like kid doesn't want to go there in the moment. Like that's hard. Yeah. But sometimes we can, or sometimes it just takes a little bit of time and then we can get there. But as you are alluding to, I mean, I really feel like a lot of this is like taking, like, okay, so we've accepted hopefully that we can't, in this moment, we cannot immediately stop the aggression. The only thing we might be able to control might be our own reaction, right? So, just to, like, are we able to sort of put the things in place in our own lives, as you alluded to, to make things more practical and easier on you? I really think about how important it can be to take that bird's eye view and think about like, well, when is aggression most likely to happen? Because sometimes if we really kind of dig into that, it can be a little more predictable. Like definitely not all the time, but sometimes it is. So for example, like, okay, the 2-3 hours in the afternoon where there's a lot of downtime and unstructured time, like that's definitely, the highest need time. Or the mornings when blah, 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 so like, is there any kind of environmental change, right? I've had, maybe a dozen or so families where it was decided in the cost benefit analysis that sort of having the non-PDA sibling kind of who was able to go to like an aftercare or like be with somebody else, grandparent, more often during the unstructured time. Now that might be painful if you feel like, your other sibling wants to be around you and that's a consideration, right? But like, these are all things.
Yeah.
We're mitigating risk, right? And then the other piece, right, is like, what is to think about is like, is this realistic, right? Like I see a lot of overwhelmed caregivers who are doing like a seriously A+ job and like these things still happen. So this is not to say that somebody's not doing what they should, but something to be thinking about is like, is there other resources we can pull in, again, more eyes on the kids to sort of be, or again, are we sort of now knowing like, yeah, usually we have this unstructured time or this type of game, where this thing tends to get triggered. So are we as the caregiver noticing like, it can feel like we went from 0 to 100, but oftentimes like there is an escalation, like there is a little bit of a like ramp up period. Maybe it's just a few seconds, but is there a way that we can see, okay, I'm noticing that like his voice is getting a little louder, a little more frantic, right? Or like his body seems a little more tense and more, movement. And so like, okay, do I need to get in there maybe before we get to the red zone, right? So, I mean, always, and like this parent is saying that they're trying to do that, right? So I get it, right? They're trying to use the strategies and it's still not working. And it's so hard, right? So I think these situations deserve a ton of empathy, right? And I think in this parent is also saying, worried about as he gets older, really valid concern, of course, right? Of course they're worried about that. And, does our worry about the future like come into the present moment in a way that's like helpful or not helpful? I don't know that it's, helpful there, right? So how do we work with that and process that? I think that when, just to get into the sibling piece a little bit more, right? Because a lot of parents ask about like impact on sibling, where like, so let's assume that maybe, let's say in this case, older sibling is having, more challenges with regulation, younger child is experiencing that, parent worried about impact on younger sibling. I mean, such a valid concern, of course, and so one of the things I like to say is that I think it's like what makes something really sort of harmful and traumatic is not so much like whether it happened or not, whether like the kid got hit or whether, they saw this massive explosion or not. It's like, did anyone kind of come back at some point to that kid to show them that they care about their experience of it and that they're on it, right? So like that is really, can be really important. Like, hey, I noticed that yesterday you saw your brother, like really break that thing. And it was a time where you were looking forward to going to get this other thing. And like, oh man, that must have been disappointing. And oftentimes parents, like we feel so much guilt and it's not in the moment. We just want to be like, kind of move on from that horrible situation. But sometimes if we can kind of have that conversation with the kid, like that can be really important. Sometimes there are patterns where kids will develop a little more like sort of, let's say the sibling of the kid who has more regulation issues. And, we can talk about it, in ways about kind of like trying to sort of put words to what the kid is experiencing, like, and not just about the negative, positive. You see your brother is so great at this, but sometimes it's really hard for him to do this. The same way it's good at this and this. I think that there's like, if you notice a child, kind of taking on like what we might see as like more of a caregiver role from a young age than might be appropriate, like sometimes it's referred to as parentification, or maybe they're sort of like not willing to like say what they want about something, not willing to really express their needs, or they feel like they have to sort of like make other people happy, that kind of people pleasing stuff. Like, yeah, I mean, that's maybe a signal that like, okay, like we want to tune into that, right? Because you can catch that and talk about that with your kid or get your kid, their own support in some cases, right? But I think generally kind of recognizing those patterns are important, like showing the child that their experience matters. You're putting voice to it, and how you understand it, and how you get it. Like, it doesn't seem fair. It wasn't fair. And, sometimes like 5 minutes of really tuned in, like very, like attention to something can go a long way, even when we barely have time to talk about these things in more detail.
Yeah. That's often when my younger son processes things or brings things up, like when we're doing the bedtime routine, and he'll be like, am I part of Cooper's team? Or he'll be like, he'll hear things downstairs because his bedtime is earlier, and I'll see his hypervigilance go, because there were years in there where like almost every night there was like a very long screaming panic attack, whether it was like the cumulative nervous system activation from school or like trying to play a video game with his dad. For us, we did separate the siblings for 3 years, essentially always, which I know, given the constraints of some people's lives, either their finances, whether they're a single parent, like it's not feasible.
Right.
But like this included Christmas. Like I would go somewhere with William and my husband would go somewhere with Cooper, holidays, vacations. It's only now that we're through that. And part of that was because William was also 3 and 4, and like didn't have his executive functioning or frontal lobe where he could regulate himself. And it was just, there was a real risk of violence and trauma, right?
Yeah.
And it was really hard on me in terms of like what it meant to have a family and my relationship with my husband, and sadness about like, are they going to have a relationship? But I kind of had to let that go in the spirit of risk mitigation. And I know for a lot of parents, like, we want to recognize, is it finances and true constraints that are preventing you from experimenting, or is it our conceptualization of what's the right way to do things and what a family looks like, and our fear that our kids won't have a relationship that's preventing thinking outside the box? And it, like, only you as a listener know as a parent, but I have seen a lot of families where the latter is the prevention, and then they try it and it's like, it actually really helps, whether it's a couple months, whether it's during certain times of the day, as you mentioned, Alex, where they can sort of just lean into like, this is what we have to do in this season. And, you know, I will say, I think for my kids, it's allowed their relationship now that we're through some of those years, because they can actually interact without fear of injury.
Right.
And like
right.
enjoy each
right.
other a little bit. And of course, it's, some days are touch and go and we do still separate, but you know, sometimes, and this is what I mean by like, sometimes it's decisions, not solutions, because, you know, I spent years being like, I need to figure out a way to make this not be how it is. And then realizing like, oh, it would actually be impossible for any person to manage this with two kids, one of whom is in burnout and fight or flight.
Right.
So
right.
just
Right.
recognizing like, you're not, there's nothing wrong with you as a parent if you're not finding like a strategy. Like,
Oh, yeah.
sometimes you're just
Yeah.
in these
Yeah.
seasons.
Yeah. And I like you said out of the box thinking, right? Because I think, you know, no one really goes into parenting. Like, you imagine having a couple of kids, like, you know, no one imagines vacations being separated out, right? Or like,
Yeah,
you know,
or like
Christmas not being all
Christmas.
together. Right. Yeah. Like, of course, you know,
Yeah.
and it does really take rethinking. I mean, I like the examples you give also, because you've also come to a place where now you can do that, right? So it is important to keep in mind that these things are often the hardest times, like these hard moments these parents are going through. Like, oftentimes it's definitely not going to last forever, right? But it is a very hard time, deserving a lot of compassion and support. So
Yeah, and this is why, like, I just need to say this, like, why I feel so strongly and I believe so intensely in the fact that our families who have especially burned out or externalized PDA kids need caregiving support, right?
yeah, totally.
Because it's not, you know, we actually contacted, forgot what agency it was, but my son had an autism diagnosis, so we were like trying to get in-home caregiving support before we had to DIY it with au pairs
Right.
from other countries and train them ourselves. But it was like, oh, he's not severe enough because he's a level 1 ASD and his social communication is good. Right? The disability itself was about safety and access to basic needs. And it included safety of my safety and my sibling, like his sibling's safety. But at that time, I didn't have the ability to articulate it. And we don't have a real clear diagnostic category that recognizes the level of intensity that the families are experiencing, where there's actual threat to safety, right? Where this isn't just a meltdown. It's not just a temper tantrum. There might be knives involved. There might be self-harm. There might be really difficult things that, you know, parents also are scared to talk about because of CPS, you know, Child Protective Services. And it's like, we've received so much blame. It's like, we almost don't want to show the reality behind closed doors, especially when people don't, quote, believe in PDA in certain circles, right?
Yeah, or the level 1. I mean, that's you know, it serves to actually, you know, mean that you're not going to get access to some supports that you would otherwise have, which is a good example of why the level system is problematic and doesn't really benefit. Usually I don't see this benefiting the child or the family. Like, I don't see how that links, but that's probably another conversation.
Yeah, that's another.
Yeah.
Okay, so we discussed 3 really complex topics. We discussed OCD and exposure versus accommodation, and enabling versus supporting, and where that intersection is. We talked about risk mitigation for traumatic or risky or violent situations, and we talked about siblings.
Yep.
So I am proud of us.
We did a lot. We got through a lot. I love it.
I hope this was helpful to everybody, and thanks for listening.
Always great to talk to you, Casey. Take care.
Thanks everyone for being here with me at the At Peace Parents podcast. This is your source for all things related to understanding, supporting, accommodating, and advocating for your PDA child. To go deeper on any of these topics, check out my course offerings and masterclasses at the website www.atpeaceparents.com. To completely transform the way you think about and relate to your child and to bring peace and stability to your home, join us for the next cohort of the Paradigm Shift program.